Welcome to the Nursing Post podcast, All Nursing All the Time with Ashley Moore and Rosa Horsley. Today, we're going to talk about the most common heart arrhythmia, atrial fibrillation.
Yep.
Our goal is always to inform and to start conversation.
So an arrhythmia happens when the electrical impulses in the heart are not working properly, and then that will cause the heart to beat irregularly, whether that's too fast or too slow. They're both an arrhythmia. AFib is considered to be a tachyarrhythmia, which means your heart's beating too fast. And this type of irregular heartbeat starts in the top part of your heart, the atria, and is actually the leading cause of stroke, which is one of the reasons why it's such an important topic and one that we really wanted to talk about.
Absolutely. And as always, we love the numbers, so we had to throw some numbers in here. It's estimated that 12.1 million people in the United States will have AFib in 2030. That's a staggering amount.
Mm-hmm.
In 2018, AFib was on 175,362 death certificates. That was the underlying cause of death. That's a lot.
Mm-hmm.
Yeah,
It really was. I mean, if you think about for all the reason people die and you're consistently seeing this diagnosis, there's something going on.
Absolutely. Caucasians are more likely to have AFib than African Americans, Hispanics, or Asian Americans. And on a little side note, African Americans with AFib are more likely to have complications such as stroke, heart failure, or ischemic heart disease. Because the number of AFib cases increases with age and women generally live longer than men, AFib is more common in women. 9% of the US have AFib, and AFib is independently associated with a higher risk of developing dementia with up to a 30% increased risk, regardless of the clinical cerebrovascular events like a stroke. Because there is, a vascular dementia
Right.
that we've talked about in the past. AFib is first diagnosed in 11 to 24% of patients with a recent ischemic stroke or TIA. And 60% of all strokes secondary to AFib can be avoided with the use of an anticoagulant.
So when we are talking about AFib, it's typically picked up on an EKG. Some patients have symptoms and some patients don't. And when you're looking at an EKG, because even if a doctor hears an irregular heartbeat, they'll typically ask for an EKG. Can you do an EKG?
Mm-hmm.
And what they're hearing is an irregular heartbeat, thump, 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 thump. Thump, 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 thump. And when you look at an EKG, if you just pull up any picture on Google of an EKG, AFib typically lacks P waves. That's one of the biggest things you're going to look for is that first little P wave before the QRS. And they don't have any. They also tend to have a more narrow QRS complex, which is less than 120. And it's one of the things you look at. Most EKG machines, actually, when it prints out, tells you what those numbers are. They're roughly correct. Depends on who you talk to.
Mm-hmm. I think and the patient too.
Yeah.
Not everybody's cookie cutter.
No, they are not. There are 4 different types of AFib that we just want to go over. There is proximal, persistent, long-term persistent, and permanent. Working in cardiology, if somebody tells me that they're in AFib, the first thing I ask them is, do they take blood thinners? I mean, it's kind of like people can live in AFib, it's fine. Some people they can't get out of it, but being on a blood thinner or any type of anticoagulant is really important because of that risk for stroke. So we're just going to go over real quick the 4 different types of AFib, and then we'll get a little bit into like just some symptoms and treatment and things.
Mm-hmm.
So the proximal AFib is when you go into AFib and then your heart returns to a normal rhythm within 7 days of onset. Some patients go in and out of AFib sporadically, and it can happen a couple of times a year. But typically, if you're doing that, you're eventually gonna just end up in AFib.
Mm-hmm.
Some people will go out of atrial fibrillation on their own. Others have to be converted, have to be given medicine to convert, have a cardioversion or whatever. But even if they go in it and come out in 7 days, whether it's on their own or with the help of medicine, it's considered a proximal fibrillation. And you of course will be followed. For persistent AFib, you're looking at something that lasts longer than 7 days.
Mm-hmm.
And these patients do not go into normal sinus rhythm, which is your typical rhythm, on their
Mm-hmm.
own. They will require some sort of treatment, whether that's medication or a procedure. For long-standing AFib is when a patient's been in AFib that lasts longer than a year. And then permanent is exactly what it sounds like. They are in AFib and everything that they've done to try to get the patient out of AFib has failed, and they're not going to do anything else anymore as far as trying to convert their rhythm. They'll just be managed medically.
So let me ask you a question, because you're the cardio nurse now. With the long-standing AFib, it says, that a patient's usually in AFib for 12 months or longer.
Mm-hmm.
Has anybody ever been in AFib longer than 12 months and come out of it?
I'm sure there's always exceptions to the rule. I mean, there's nobody that's like, oh, that never happens. No, I'm sure there is. I think with a permanent AFib, there's been so many different things done, whether it is cardioversions, ablations, and whatnot, that they just say, I'm not doing it anymore. The patient typically says, I'm not doing it anymore. I'm not doing anything else. I'll take my medicine to keep my heart rate in control. I'll take my blood thinner so I don't have a stroke, but I'm not doing anything else. I'll just stay in AFib.
Got it.
I think that with that, a lot of those patients, they know they're in AFib, but it doesn't impact their day-to-day life.
Yeah.
I mean,
Okay.
we have a couple of patients, one actually that I know personally. She's been in AFib for years. She's tried several different things. There's certain things she's not willing to try, and she's like, I'm just not going to do it. It does make her very short of breath. She is morbidly obese, which doesn't help.
Doesn't help. Yeah.
She's in kind of a catch-22 because any activity causes her heart rate to spike and she really feels poorly. But so she doesn't do as much activity, which then in turn
leads to the other issues that she already has.
Right. And so it is sad for certain patients like that. But her likelihood of just saying, okay, she's now back in a regular rhythm, is just probably not going to happen.
It's not going to happen for her. Well, there are some symptoms for those who suffer with AFib. Of course, I think one of the most common ones is fatigue.
Mm-hmm.
The other one is, heart palpitations. If you're a nurse, I think you can kind of expect that, because when your heart is tachycardic, it's beating so fast that you could probably feel it. You could probably feel the palpitations. You might have difficulty breathing, especially when you're lying down. You can imagine that there may be some chest pain associated with that. Hypotension, which means low blood pressure. You might have periods where you feel dizzy or like you're going to faint.
Mm-hmm.
Remember, your heart and your blood flow, all of it is compensating.
Mm-hmm.
So if it's beating very fast, it's trying to compensate in other areas, because that's not what your body is saying is homeostasis and normal. Palpitations are usually more common in paroxysmal AFib. Shortness of breath is more common in chronic AFib, and not all types of AFib are symptomatic. So people can have AFib, and I can assume that they wouldn't have any symptoms at all.
Some don't. Yep, none.
There are some treatments that I know Ashley is probably more of an expert on than I am, since this is her specialty.
It's funny. A lot of the patients who come in, they'll ask them if they have any symptoms, and some look at me like I am crazy. Of course I have symptoms. My heart is beating 140 times a minute. And, I laugh, and the others.
But is their watch telling them that, or do they really, really feel that?
No,
everybody's walking around with a watch now. So even I can tell you, hey, my heart rate's 121.
Oh, don't get me started on those watches. And others will come in, and I'll look at the screen. I had a guy come in the other day, and he was just going, and I'm like, you feel okay? And he's like, yeah, I feel fine. You don't have any trouble with your heart racing or fluttering or feeling bad? Nope, nothing. Dude's like 138, has no idea. And so it's amazing. Some people don't feel anything. They feel fine. And it's almost scary. You'd rather feel it, when you're in it, versus not. But
I wonder if his body has just compensated, or he's learned how to kind of compensate, and now he's like, I don't feel anything.
Well, a lot of them that do come in that are symptomatic that I've seen just firsthand, I'm like, hey, what symptoms did you have that took you to the hospital? I don't know what was going on with me. I just knew something wasn't right. They didn't even
Hmm.
realize it was their heart.
Oh, wow.
They just knew that they felt so bad and that something was so wrong that they needed to get to the hospital. It's
Well,
like,
you always listen to your heart and your gut.
right. And so they're like, I didn't know that it was, then they'll tell you, I didn't know it was my heart. I had no idea they were going to tell me anything was wrong with my heart, but I knew something wasn't right. And it's amazing to me to hear that. And I hear it over and over and over again, just because I find it so interesting that they don't have any symptoms. It's like, really?
Yeah, if my heart rate was at 150 something, I'm probably thinking, oh, I felt something.
Well, yeah, and that's what
Yeah.
I thought. I'm like, there's no way these people don't feel this. Sure enough, looking at you like, I'm fine. I had a lady the other day, she come in, had palpitations like a couple of days prior, and her primary said, oh, just follow up. And we follow her for CAD. And I asked her, I said, well, how are you feeling today? Just having conversation. And I was like, well, let's just go ahead and do an EKG, since you were having some trouble then, just see where you're at. Sure enough, she was an AFib. I looked at the doctor I was working with, which I don't typically work with her. And I said, I'm sorry, every time we work together, I give you a new onset AFib. And she's like, no, not another one. And I was like, yeah, I'm sorry. But sure enough, she just was hanging out reading her little book.
Okay.
So I find it to be interesting. But there are a bunch of different treatments. What we've kind of come up with is not an exclusive list by any means, but I think it's kind of the most common ones that you see. There are antiarrhythmics, which are medicines given to help decrease your breakthrough arrhythmias. It doesn't necessarily mean that you're never going to have any. We're just trying to make it to where we get it as little as we can.
Mm-hmm.
Think, oh, well, I had, one issue, and so therefore this medicine's not working. It's like, well, no, one issue is better than 20. It is
Absolutely.
It's just there are breakthroughs. And some antiarrhythmic drugs may cause ventricular proarrhythmia. They can cause conduction disturbances. They can cause heart failure. So they're not medicines that you just throw somebody on and say, okay, we'll see you in 6 months. It does require close follow-up. We bring them back very frequently just to have EKGs, to have the doctors look at them, things like that. Some have to be started in the hospital and monitored for several days. There's a whole bunch of different ones out there, but a lot of options. Some of the patients who live in AFib, those permanent AFibs, or even ones that kind of go in and out, some of the times we just worry about rate control. And so we want to make sure that you're in a good rhythm, but we also want to make sure it's at a good rate. Like you can be in a normal rhythm, but still 120 beats, that's too many. You're still going to kind of feel bad. So a lot of what we do for the rate control is to control the ventricular rate, the bottom parts of your heart. And that helps reduce signs of circulatory insufficiency. It does help with like tachycardia, cardiomyopathies, just, the enlargement of the heart, because your heart it's working really hard.
It's overtime. Yeah, at this point, it's just working overtime.
And you can use things like beta blockers, calcium channel blockers to help with rate control. There's a whole bunch of different things. If it gets to a point where you have to have certain procedures done, we can insert a pacemaker to help with rate control as well. So there's a lot of different options. That's nowhere near all of them, but just different medicines to help keep your heart rate within normal ranges. And again, it has to be monitored because your heart rate can be too low, and you don't want that either.
No, because then that's a whole different ball game. I mean, the low side even more so than I think the high side.
For cardioversions, that is where they pretty much shock your heart to get it back in a normal rhythm. Before you have a cardioversion, you'll be given some kind of blood thinner that you have to take. My current practice, they want you on it for at least 4 weeks uninterrupted, period. And
wow.
You miss one day, you start all over again. And there's no gray to that.
No.
And that just helps because of blood clots. Because if you're in an abnormal rhythm and your heart is not pumping correctly, blood that sits coagulates, creates a clot. Then we get it to pump well, and then we throw clots everywhere.
It's going to be throwing clots. Absolutely. You shock your heart. They shock the heart, and then there they go.
Right. And so do have to do that. If for some reason it's emergent, where like they just haven't been on blood thinners, but something has to be done, they'll do something we call a TEE, is a transesophageal echocardiogram. And ultimately you just look in the heart, go down the throat, put an ultrasound on the backside of the heart, and see if you see any clots in there. If there are no clots in there, you're good to go. They'll zap you. The electrical cardioversion, that's where the electrical shock is delivered through your heart, through paddles on your chest, kind of like the stuff you see in the movies. They amp up the joules and hit the button. And
everybody clear.
It stops your heart kind of just for a moment. And then the hope is when your heart restarts back up, it starts in the normal pattern.
Normal rhythm.
You know, which is right to left, top to bottom. Is how the electrical path flows through your heart. Now, those are usually like your starting points. You can have a catheter ablation done, which is more invasive. That is where a electrophysiologist, which is a heart rhythm specialist, is what I tell all the patients it is. I call them EP doctors. They will actually numb your groin, go in just like they're doing a heart catheterization. They put in a couple of catheters, helps, you know, guide where they need to go. And once they're in place, there are electrodes at the ends of the catheters, and they stimulate certain areas that are known to cause AFib. And when they see the area that is actually causing the irregular heartbeat, they pretty much cauterize it, and then it can't cause a problem anymore. There are some doctors who will use just light sedation, and then some will do general. And a lot of that depends on the expectation of what all has to be done.
I can see that.
Some of them go in with the expectation of light sedation. I had a coworker who had an ablation done just a little while ago, and the EP doctor just looked at her and said, "Look, this is what I plan to do, but if I go in there and it's a hot mess, I'm just going to knock you out and do everything." And she was pretty much like, "Yeah, please do that, because I don't want you to come out, me recover, and then have to go back
and do it again." Yeah.
So that's usually a conversation. They would say, "Well, hey, while we're in there, this is what we'll do."
So then there's another procedure called the Mays procedure.
Yes.
And it's evolved over many years, and it's actually now called Mays-Cox 4. This was formerly known as the Cox-Mays 3, a cut and sew procedure. That sounds like operating on a rag doll, but anyway.
It's very like horror movie-ish, isn't it?
Yeah, it reminds me, in like my mind, I see the movie Saw, but anyway. Moving on. Instead of actually cutting an energy source, heat or cold is used to create scar tissue, and this blocks electrical activity, which in turn stops the arrhythmia. The surgical ablation method is faster than Cox-Mays 3, and it's just as effective. And since this is an open chest procedure, it is usually performed on patients needing open heart surgery for other issues like a valve replacement, repair, or a CABG. There is an option for patients who only have AFib and lack other heart disease, the mini Mays procedure. I think this one would probably be the one that I would like to go for if I had an option. This is done by making several small incisions into the chest to advance tools and a camera. The cardiothoracic surgeon then blocks the electrical circuit at the pulmonary veins with an ablation tool to stop the arrhythmia. The surgeon will also ablate the ligament of Marshall, the ganglionic plexi, and will clamp off the left atrial appendage to reduce the risk of blood clots and stroke. God. Just give me some Coumadin and a beta blocker.
And there are so many people that actually opt for that. It's funny because you say that, but a lot of people are like, I don't want to go through all that. Now, if you're already having open heart,
well, if you're in by all means, fix me up. Like if you're
Right.
already in there. But if I had the option, I'd just be like, give me the 2 pills and I'm fine.
Yeah. And a lot of people do that. And now, with that left appendage part added, even people who have AFib who can't tolerate blood thinners can have that procedure done as well,
Mhm.
separately, to where they can have, we call it a Watchman. I think there's other things that are out there that can be done. Same concept, different, manufacturer. But it's really nice where we can offer all these things. But the biggest thing that pops into my mind is how much messing of one person's heart can you do? And ultimately, it's a lot more
Well, it is
than.
a muscle, but then like when you're talking about cardiac issues, that muscle's not in top condition.
No, it's not. And so there are some people that go through a lot of these issues and can still have problems. Now, the maze is supposed to be something that permanently fixes AFib,
Mhm.
but we know in medicine there are no absolutes.
Yeah. I was about to say absolutely, but then that would be an oxymoron. Um,
Right.
but you're right. Nothing is 100% in medicine, and
Mhm.
this may take you out of AFib, but it may not keep you there. And then, if you remember earlier on, the longer we live, the higher our chances are of getting AFib. And then, if you're a woman, on top of that,
Mhm.
like you may think in your mind that this might be like the cure, but who's to say in like 5 or 10 years later, you're not back in AFib.
Right. And and I don't see this quite as often. Even working with EP, I think it's a lot of long conversations, but the AV node ablation, and that is the last treatment option for AFib, because at that point you're placing a pacemaker. So once the AV node is ablated, the heart no longer has the ability for the atria to cause the ventricles to contract.
Mhm,
The top part and the bottom part do not talk anymore.
mhm.
And when
They're not communicating. They're like,
when that happens, then there's no way for it to contract. There's no way it knows what's
mhm,
going on. So once that happens, because that's, again, they're not talking, there's no way for the ventricles to contract. Um, the ventricles alone, the electrical activity that's there isn't enough to sustain you. It's only about 34 beats. And, that's just not enough. If you're getting up running around, 30 beats is not enough. 40 beats is not enough.
no,
You're gonna feel like poo.
yeah. For instance, last week I had a resident who has a pacemaker. Pacemakers aren't for life. And I consider them like motors or transmissions in a car.
They have
They have a
batteries.
life, expectancy,
Yep.
And I had a patient last week, literally, history of a pacemaker.
Mhm.
Apparently, her batteries have decided to go out. Literally fainted.
Yep.
Thank goodness that she was walking with physical therapy, and physical therapy was able to, catch her and lay her to the ground. Her heart rate was literally 30. So
Yep.
her pacemaker, needless to say, is not working.
Right.
Unfortunately, because of her age and other medical issues she has, the family and the doctors decided not to replace her pacemaker because, replacing pacemakers are an option. Like I said, they don't live forever.
Mm.
So, yeah, I can tell you at 30 to 40 beats, she was feeling like poo.
This is what's irritating, and I'm gonna get on my soapbox because it's what I do. So I had that very question with actually one of the EP doctors a couple of weeks ago, where I'm like, so we know this person has about 3 to 4 months left on their battery.
Mhm.
Well, at that point, my mind goes 3 to 4 months left. It's keeping me alive. like this person was 100% dependent pacemaker. They didn't have any leftover residual 30 beats. They had nothing.
Wow.
So if the pacemaker stops, they have no heartbeat.
Yeah.
And I was like, okay, do you want me to go ahead and get things going for, getting replaced? We can't do it yet. I said, what? What do you mean? The insurances and all these regulatory institutions, you have to have this lady come back every month until it gets to be so close to having that battery replaced that they like it within 30 days. So they want you to get that battery that is sustaining life. I want you to take it all the way until it has 30 days.
Has COVID taught us anything?
And so I'm like,
Remember when they shut down procedures and when they shut down, you know what I mean, operating rooms?
right. Well, these are considered emergent, so they get done anyways because they have to have them. But I just sat there for a second and I was like, really? Really? That's where we are? And he's like, yeah, it's super frustrating because you're asking us to determine how long these batteries have left. And if we get it wrong, we being the manufacturer of the machine, all these calculations they're doing to how much the patient's using the energy and how much the battery should have left is ridiculous. That we're trying to make all these determinations because we don't want to replace it at like a 2-month mark or a 3-month mark. And say something happens and a patient like misses an appointment or something, then it's into even another stickier situation. I'm just like, we're just like asking for trouble with all of these stipulations. It was ridiculous. Like, we know it's going to happen. So, and sometimes they do get wrong. We had one guy that come in, he was there doing his monthly checks. Last month he had 6 months. We pulled the thing and I remember looking at the report when it came off and I'm like, huh. And I take it I literally walked it right back to the doctor and I was like, look at this. Is this right? And he like looked at it and he was just like, that's not good. The guy had like less than 3 days on his battery.
Oh my gosh. I can tell you my little lady came back on hospice.
Yeah. I mean, it's just at that point, you have to.
What can you do in 3 days?
That was one of those emergency. And of course, that was like at like the height of COVID. And they were like, has he had a COVID test? No. We weren't vaccinating at that time. So there was no option like, is he vaccinated or anything? So that wasn't even an option. And I was like, no. And they're like, well, they'll have to have a COVID test and the results are going to take 3 days to come back before we can get on.
Man does not have 3 days.
And I'm like,
it's like, lady, we have a mathematical problem here.
Right. And it's so frustrating because they're reading a script and you're trying to not get frustrated at them because they're reading a script. And finally, I was so frustrated. I went to the doctor and I was like, I can't talk to these people because all they keep telling me is he has to have a COVID test first before they'll do anything. And then he got super frustrated because now he has to stop what he's doing to make a phone call
to them.
To fuss because nobody will listen to me. I'm like, I'm not the one doing the dang procedure.
Do you think that people who have pacemakers and who had COVID used their batteries a lot more than people who didn't?
I don't know the answer to that. I have not heard of any correlation between the use of patients who were COVID positive because it all depends on how much it's doing for you. Like with anything, like if you use a flashlight every day for 10 minutes, that's going to run out faster than if you use it once every 6 months. I mean, it's still a battery. So the more you use it, the faster the battery life goes on it. I mean, so if they're having to use it more for any reason, then the battery is going to go on it quicker, period.
I'm just curious to see like what somebody's report was before, they had COVID and maybe what somebody's report says after they had COVID.
Right. Yeah, I haven't seen anybody come back where like there was a dramatic reduction in what the last report said after a hospitalization or anything like that. Because if they come in, and we're working, I mean, we pull reports every time they come in. We interrogate them. So.
We wanted to end the podcast with some information on watches that populate EKG tracings and their accuracies. There is data consistently coming out about this as more and more research is being done. And one study that we found interesting was a study that looked at 50 post-op cardiac surgery patients at Cleveland Clinic. And since AFib is common after cardiac surgery, the researchers chose to study cardiac surgery patients. Makes sense.
Yeah.
Patients were provided an Apple Watch 4 at random and provided with instructions on how to activate the heart rhythm reading on the app. There was also an automatically generated PDF of the waveform on the Apple Health app that was then exported and a rhythm strip was saved. And the Apple Watch 4s, 5s, and 6, they all have this capability of doing the, EKGs and monitoring your heart rate.
Yep.
So half of the patients had more than one occurrence of AFib during their hospital stay, which was 90 episodes. The telemetry ECG picked up about all 90 of those AFib instances.
So the Apple 4 Watch app only, it did correctly identify 34 of the 90 instances of AFib, which is about 41%. And the 25 patients who had more than one episode of AFib, it was identified in 19 of those patients. So that number went up quite a bit. In patients whose hearts were in sinus rhythm, there were no notifications of AFib. So that leads us to believe that there's not a lot of false positives.
Awesome. That's good news, actually.
Yes. I mean, it's about half accurate. 41%-ish. It goes up even more so if you have more episodes, which I guess gives you a better chance to catch it. And that's for the app only. Now, if you have a Apple Watch that does the retrievable PDF, that does the actual waveform strips, of the 284 rhythm assessments that were gathered, in 8 instances, a reading failed to generate. And so these were counted as an incorrect rhythm strip because it was an issue. But it correctly identified 84 of the 90 instances of AFib. So that's at 96%.
That's a very high, significant, it's correct.
Yes.
96% is a lot.
And the 25 patients who had more than one episode of AFib, the PDF waveform strips did show AFib in 24 of those patients. And the patients who were in sinus, that's your normal sinus rhythm, there were 0 issues where AFib was picked up if there wasn't any. So again, there were no false positives. So I think a little bit to be said for that is these waveform strips are great if you can read them.
Yeah, so I would think based on these results that the waveform strips are definitely more accurate than the app display.
Yes.
And how do you feel about phone makers or smart watch makers being more invested into the health side of things? Now some say they can take your O2 rate, some now say they can take your blood pressure, some like Apple Watch can take a waveform of an EKG. Where do you see this going?
Oh, I see us definitely increasing the amount of home equipment that is readily accessible, that's included in other things, scales that include things more than weight. different things like that. Just because a lot of this stuff, people feel bad, they don't want to go to the doctor. Like, if I have to be about dead for me to go to the doctor.
I hear you.
I don't want to go.
Not saying that that's right, because as nurses, we have to take care of ourselves. And here we are preaching, to our patients that don't delay, don't wait. But I tell you what, nurses make the worst patients.
We do. And we know that. And, quite frankly, I'm okay with that. I try to be understanding, but, I do see where it could be very, very, very helpful. But then I can also see where it could very much increase anxiety in people who have no idea what they're looking at and not being able to differentiate between artifact and things like that.
So have you seen, since you're in cardiology, do you feel like you get a lot of calls about this, or a lot of visits about people saying, hey, my watch said that I'm an AFib, or my watch said there's something not right with my heart?
Yep, we do. We're getting more and more and more of them too. We have one guy who actually, his watch was telling him evidently that he was in AFib all the time. And he had one that he could actually print out these PDFs. So they come in with their strips.
Mm-hmm.
Which is great, because it's like, okay, well, this is where I felt bad. This is when I felt bad. This is when I felt bad. And, she's looking through all his stuff. She puts him on an actual heart monitor. Mm-hmm. He wore it for a while, and it come back that his PVC burden, which is all he was having was PVCs, was at 1%, which is, pretty dang good. Honestly, mine is higher than that just because of the amount of coffee that I drink.
Let's skip the caffeine.
It's a price I pay. I'm okay with it.
Yeah.
But every time he has like a PVC, his phone dings and tells him he has an abnormal rhythm. And he is literally sending us stuff all the time saying, it gave me another one. It gave me another one. It gave me another one. It's like, yeah, they're PVCs. And some of them are not even real PVCs. It's more artifact, and it's off of a watch. So it's not the best. And trying to convince him that we had you on a heart monitor for 30 days where you wore this, studied and approved piece of medical equipment to say that you are in a completely normal rhythm with some occasional 1% PVCs, you're okay. He just doesn't believe it because his watch doesn't tell him that.
Yeah. I've had a patient like that when I was in pulmonary who said that I don't know how to take their heart rate, their O2 stats, or blood pressure because their watch tells them different.
Well, yeah, but nobody talks about the oximeter is incorrect if your hands are cold. Nobody talks about that. Everybody just knows that what they see on their screen fits their narrative of whatever it needs to be. And they need to understand how to clinically correlate that. Now, I'm not saying that doctors are not ever wrong. Lord knows I am not saying that. They are. It's happened. It will happen again. However, if you are seeing, this guy was on his third cardiologist, had told him the same thing.
Yeah, it's time to let go of the watch.
And at that point, that's when you're like, oh my gosh, I want to throw that dang thing in the trash.
Well, it was just like when we were working pulmonary, and if you had a CPAP machine, they would, you got the app. I look at your face now and you're like, oh Lord. Yep. They would be like, well, my app said that I stopped breathing 8 times last night. I understand. And we're like, yes, you have sleep apnea. That's why you wear that device so that you don't.
Or like, I'm just like, I just don't even sometimes reason with them. I just leave it for the doctor. I'm like, I can't. If they're not going to listen to the doctor, they're not going to listen to me.
No.
It can get super frustrating just because they don't always know how to interpret the results. And that's really not what they're supposed to do. So I can see why they're like, okay, well, and I'm like, okay, well, if you can't interpret the results, you came to somebody who could, great, but then you don't listen to them, so then it's mute.
Yeah, that's what's the point.
And there
Mhm.
were a whole bunch of those studies. They were all kind of smaller studies. And I
Mhm.
think it's just getting to the point to with we're seeing it so much more in medicine now. You know, my watch, my watch, my watch, that health research, everybody is like, okay, we're hearing about these dang watches. We need to know how reliable they are because
Mhm.
we can't affect, these are not good enough to treat somebody off of. No doctor is going
Yeah.
to see these readings and say, okay, great, here's some medicine. Glad you caught that. It's not going to happen.
I mean, you hear the stories on the news, and they're not a lot, but my watch saved my life, or
Mm-hmm.
it was accurate. It had so many of these episodes that it led me to see my PCP, and I was
And
effectively diagnosed.
that is the perfect way to utilize them. Like, that's what I think everybody wants to try to get across is this is not for you to doctor yourself at home with. It's a tool to let you speak with your provider about, so that way you can get treatment faster, easier, and before it becomes a problem. Because you don't want to realize you have AFib when you have a stroke.
No, by then it's too late, and I think that's the perfect point. You can find our references on our website, thenursingpostpodcast.com, and subscribe to our podcast on your favorite platform. Be sure to leave your thoughts and opinions or comments because, believe it or not, we do read them all. Thanks again for listening to the Nursing Post podcast, and we will see you next time.